what we use now But what we use nowadays is more of a dermatoscope, and I'm going to talk about it in a bit. Wood's lamp also can help augment you in your examination if you're looking at pigmentary and infectious lesions. And then you can use a camera, obviously, for standardized documentation and follow-up comparisons. So what is the dermatoscope? And this is what I was just telling you about. So a dermatoscope is a handheld device. It typically offers a times 10 magnification. It uses something called a polarized light, and that light is able to eliminate surface reflection. So you can actually see deeper structures in the skin rather than only surface structures. So it enables you to look at pigment networks in a better way, at blood vessels, at hair follicles and hair shafts, and this aids in a more accurate diagnosis. So these are a few examples of how specific skin lesions look under the dermatoscope. So over here, for example, you can see your pigment network in melanoma. It's an atypical pigment network. It's not symmetric, and this makes us, worried that this is not your classic melanocytic nevus. This one, for example, is a classic melanocytic nevus. It's quite symmetric on both sides. For example, other lesions like vascular lesions, so you can see the vascularity in the form of globules. They're either red or purple, depending on the vascular lesion. So it really helps you look at specific details in a lesion. BCCs, for example, sometimes have microulcerations that you can't see when you're examining and you need a dermatoscope. So it's a 10 times magnification. What is the Woods lamp? A Woods lamp is another device, handheld device that we can use in clinic. Basically, it's a device that emits ultraviolet A radiation at the wavelength of 365 nanometers. So you need to put the patient in a dark room, and this can help us detect either pigmentary changes or infectious changes. And what happens is when you put the light on the lesion, if it has any infections that produce specific substances, these substances are going to fluoresce and they're going to give you distinct colors. For example, in this picture over here, we have erythrasma with the bacteria that's releasing specific substances that basically emit orange fluorescence when they're under UVA lighting. So it can help you diagnose infections like tinea, erythrasma, or pigmentary changes like vitiligo. So vitiligo sometimes won't look very clear when you examine them without a Woods lamp, but when you get the Woods lamp, the white light starts to become more bright and it looks milky white under the Woods lamp examination. So how are you going to conduct the steps to conducting a skin examination? So we talked about the tools, we talked about the lighting, we talked about ensuring patient privacy and that you want them exposed so you can examine them clearly. Once you have the patient comfortable in bed under good lighting and the patient's already exposed, you want to start overall with a general inspection. You want to look at in your brain, obviously. This is quickly. It's going to, with time, obviously, it's going to just pass by. You're not going to think of it. It's going to be something that's going to be passive. So you're not even going to sit and say, okay, I did this. No, khalas, it's going to happen very naturally. So you're going to look at the patient, you're going to notice their skin type, and we're going to talk about different skin types in a bit because specific skin lesions can look different on specific skin types, and specific diseases tend to occur more commonly on specific skin types. So for example, skin cancers, AKs, so actinic keratoses, BCC, basal cell carcinomas, SCC, squamous cell carcinomas, melanomas, we see them a lot in skin type 1 and 2. So redheads, blondes, blue eyes, we don't see them as common in darker skin types. It's only in specific situations we can see them more commonly. So that's why skin type is very important. Obviously, you're going to look at the color of the skin, the color of the hair, the color of the eyes. This all gives you an overall appreciation of what your differential is going to be later on. You clearly want to look at the hair, the nails, just to have an overall idea. And then you're going to do your detailed inspection. So whether you want to start with the skin first, you want to start with the scalp, whatever you want. My approach is obviously I go first to the most problematic area for the patient. So if they're coming with a skin lesion on their dorsal of their hand, I'm going to go inspect that first, obviously. And after I inspect it, I also palpate it, and we're going to talk about that. And then I move on to examine the rest of the body from head to toe. So you want to do the scalp, you want to look at the hair, don't forget behind the ears, don't forget the ears, back of the neck as well. So you have specific lesions that occur in these places. And then you want to do the trunk and extremities fully. Don't forget your palms, your soles. And then at the same time, while you're looking at the palms and soles, look at the nails at the same time and the nail capillary fold if you're looking for specific diseases. And then lastly, you want to look at the oral mucosa, and then you want to look at the genitalia if needed. Once you're done inspecting, you want to palpate obviously at the same time. Why is palpation important? Because different lesions present with different depths. And you won't be able to appreciate it as much unless you palpate it. And we're going to talk about the different primary and secondary lesions based on palpation. But you want to look at the texture. You want to feel the temperature. Is it tender? Is it not? Is it hot? If it's elevated lesion, is it mobile? Is it stuck? Is it fluctuant, etc.? And we'll talk about all these in a bit. You can definitely do special tests. Like we mentioned, you can use your dermatoscope, you can use your Woods lamp, but you can also do special tests on the skin itself that helps you diagnose. So for example, you can check for dermatographism. If you're thinking of urticaria, you can just get, a Q-tip, and you can do a little bit of a scratch on the patient's forearm and check if they're going to have an elevated red wheal. You can also look for derriere sign, for example, in urticaria pigmentosa. You can look for Nikolsky Aspo-Hansen when you're looking for blistering diseases. So what's the difference between Nikolsky and Aspo-Hansen? Nikolsky is basically when you're doing tangential pressure on normal looking skin, you're going to induce a blister formation. And Aspo-Hansen is when you have a blister already that is popping over there, applying pressure on it is going to expand it. And this is what Aspo-Hansen means. And this just tells you that the skin is fragile, that the skin is able to produce blisters. And you can do a lot of these other special tests. So you can do scraping, for example, for KOH. You can look under the microscope. All of these are things that you can do to aid you in forming your differential diagnosis. And then lastly, obviously, if you have a team of nurses that can document and do photography, that would be amazing. If you have a specific system, obviously, in the hospital, that would be great. So taking photographs, you want to do an overall photograph, and then you want to do, zoomed in photographs. And then obviously proper labeling of the photographs are important. So they're good for follow-ups, and they're actually even good if later on you want to conduct research or you want to teach patients, teach residents, you can have photos that you can use later on. So in terms of skin phenotype, what I was telling you, when we first walk in, we want to look at the patient. So what do we mean by skin phenotypes? So skin phenotypes are different skin colors, and we have a specific scale called the Fitzpatrick scale of skin phenotypes. So how did this scale develop? Basically, it refers to how a person's skin responds to sun exposure. What does that mean? Do they have a tendency to burn, or do they have a tendency to tan? If they have a tendency to burn, that means they're usually more white, and they do not tend to tan, or they tan very gradually. And that basically is your redheads and blondes and lighter skin tones. And then the patients with higher Fitzpatrick, so 3, 4, 5, usually those are the ones that don't burn easily and they tend to tan. And why is this important? Again, as I mentioned, we have specific dermatoses that occur in specific skin colors, and that's why it's important to know this information. So if you have a Fitzpatrick phenotype skin 1, that means that they're white, they always burn, they never tan. 2, they're also white, but they burn easily and tan with difficulty. 3 is beige. Most of our patients fall between 3 and 4. So beige, where they mildly burn and they tan gradually, and brown is where they rarely burn and they tan easily. And then 5 and 6 is dark brown and black, where they very rarely burn and tan very easily, or they never burn and tan very easily. So what do we mean now? Moving on to morphology. Does anybody have questions on conducting a proper skin exam? Or should I move on to morphology? Okay, so I'll move on to morphology. And then if you guys have questions at the end, you can ask me. Wait, I see the chat. Okay, crystal clear. Thank you, guys. Awesome. Okay, so moving on to morphology. What is morphology? So morphology means a native language that dermatologists use. So it's a language that dermatologists build to describe the appearances of skin lesions irrespective of their etiology. What does this mean? That means that I don't care why this lesion is happening. So when I look at this patient's antecubital fossa, I know this is eczema. It's very clear that this is eczema, but I want to use a lesion to describe this lesion without persuading you to diagnose it in a specific way. I want you to build a differential, and then based on the differential and the distribution of the lesions, I want you later on to give the diagnosis, and then we'll reach to an etiology. So meaning that it's a broad language that we use to discuss lesions, that it's a broad and uniform language that we use to discuss lesions without pointing finger to the reason why this lesion happens. So when someone in the note, for example, writes this is an eczematous plaque on the dorsal arm or on the antecubital fossa or whatever, this is actually a wrong description of morphology. You have to describe it accurately. So this is an ill-defined erythematous plaque with secondary excoriation. And this gives me a broad differential where I can put atopic eczema, irritant contact dermatitis, allergic contact dermatitis. I can build a lot of different etiologies based on the morphology that you gave me. So what are the morphological terms that we use? We either have specific primary skin lesions or secondary skin lesions. What's the difference between them? So primary skin lesion refers to the form or structure of the most characteristic, most distinctive individual skin lesion. So it's the striking skin lesion that the patient has. It's the thing that's going to draw you most to the patient, or is the biggest lesion, the most concerning, etc. Secondary skin lesions, those are skin changes that occur to your primary skin lesion or occur to normal skin due to effects of either exogenous factors or temporal changes that occur while the disease is evolving. What does that mean? That means if you have this eczematous plaque on this patient's dorsal, on this patient's antecubital fossa, either of two things. One thing is that an exogenous factor such as scratching is going to induce excoriations. So this is what a secondary skin lesion means, or the temporal changes that evolve. They're chronically during the course. So for example, they had an acute eczema and they developed a vesicle or a bulla. Bullas have water, right? So as they evolve, the water is going to leak. So they're going to have serous fluid. And then later on, the serous fluid is going to crust. So this is basically the evolution of the lesion. And then you're going to develop a secondary skin lesion, which is your serous crust because of the primary skin lesion. Okay. So why is morphology important? So I said that we need it. It's the native language of dermatologists. We want to describe the skin lesions, irrespective of the etiology. So why is this core language of dermatology important? Because that dermatological diagnoses or differential diagnoses are based primarily on morphological pattern distribution and evolution of skin lesions. So when we understand morphology, it allows clinicians to generate an accurate differential diagnosis, even before lab investigations and histopathology. So even before you going, first of all, you may not even need a biopsy. You might not even need a lab. You may actually, just based on your visual examination and your accurate description, you may be able to reach to a diagnosis, which is actually a lot of times in dermatology. Or you build a differential, and then this is going to aid you in reaching to your diagnosis, so accurately describing the skin lesion. And it actually can help choosing a biopsy area. So you want to choose, you don't go and choose a biopsy area where you have a lot of secondary changes onto it. So you know it's not really going to show you what the real disease is. So by knowing which is your primary skin lesions, you're going to appropriately go and appropriately investigate and biopsy the correct site. So without clear morphological description, sometimes communication even between clinicians are not accurate, and that's why it's important to have specific morphological terms that we use between each other so that diagnosis does not become compromised. And that is why standardized terminology matters. Okay, so when I explain to you, I want you to understand what I mean. When I tell you it's a macule, it means you know that this lesion is not elevated. You know that this lesion is a discoloration. So we have a shared descriptive language that ensures clarity between clinicians, residents, and pathologists. And that's why it's important. It minimizes ambiguity and enhances clinical reasoning. So both of us, when we both describe the same lesion similarly, we can reach to a similar differential diagnosis list. And using this consistent terminology allows for reproducibility and consensus in diagnosis. And then also having this standardized terminology ensures accurate documentation, accurate teaching, accurate research. So basically, it's something that we all use universally. It just makes our life easier. We're all on the same wavelength, basically. So now that we understood why this morphology is important, we're going to talk specifically about the morphological terms that we're going to be using and how to accurately describe skin lesions. So the morphological terms that we use are either primary skin lesions or secondary skin lesions, like I just said. So the primary skin lesion is the most distinctive skin lesion or most representative skin lesion of the disease, and secondary are changes that occur to your primary skin lesion because of either evolution of disease itself or exogenous factors that happen. Once we describe the primary and secondary skin lesions, as you see over here, so your macule, papule, plaque, we're going to talk about all of them. Later on, we're going to move on to different characteristics and how to appropriately describe morphological lesions morphologically. So what are the different primary and secondary skin lesions we have? For our primary skin lesions, we have macules and patches, papules and plaques, pustules and nodules, cysts, vesicles and bulla, petechia purpura, ecchymosis, wheal, and boro. Some of them are more broad, some of them are more specific, like wheals and boros. Secondary skin lesions that we have are excoriations, erosions, ulcer, and fissure, crust, scales, atrophy, lichenification, and infarct. And we're going to go over each one, don't worry. So we're going to start off with primary skin lesions. So the first primary skin lesion over here that we have, like you see in the picture, so this is a macule. So what does a macule mean? Universally, if I say a macule, you should know what I mean. If you say macule, I should know what you mean. So we both understand that a macule is a less than 1 centimeter. In some sources, it's less than 0.5. It's a flat, circumscribed discoloration that lacks any elevation or depression, meaning that so if I always tell my residents, if you close your eyes and you put your hands on the patient's skin, you're not going to know that a lesion exists over there. And this is what a macule is. Okay, so no elevation, no depression. It's just a discoloration in the skin. The difference between macules and patches are basically size. Macule is less than 0.5 or less than 1 centimeter. A patch is just a bit larger, so it's more than 1 centimeter. Flat, circumscribed discoloration that lacks an elevation or depression. Which takes us to papule. So papule is very similar to a macule. However, it does have an elevation. So it's a less than 1 centimeter elevated circumscribed lesion. So the elevation is usually related to changes that occur in the epidermis and dermis. And the difference between a papule and plaque is the, again, size. Okay, so the plaque is just more than 1 centimeter elevated circumscribed skin lesion. Which takes us now to nodule. So nodule is similar a little bit to a papule. Then what's the difference between it? The size and usually the depth. Okay, so it's elevated, circumscribed lesion. However, it does have a larger volume, so usually more than 2 centimeter. And the depth. So the elevation is not only because the lesion involves the epidermis and dermis, usually you also have subcutaneous involvement as well. Okay, and you can see over here, these are the rheumatoid nodules. So this is a fibrous papule of the nose, this is a psoriasis plaque, and then these are rheumatoid nodules of the elbow. So these are your classic presentations of the lesions that we just spoke about. So moving on to things that have fluid inside them, okay? So now we're going to first talk about a pustule. So pustule is super easy. From its name, it has pus, right? And that's why it's called pustule. So a pustule is usually less than 1 centimeter. It's an elevated, so it's similar to a papule, but basically it has pus inside. So it's elevated circumscribed lesions. However, it's filled with purulent fluid or pus, okay? Sometimes people, obviously, when they describe, they also mention if it's follicular versus non-follicular because it gives you a better ability to build a differential diagnosis. So if it's follicular, you want to think of folliculitis and all of your differential diagnosis related to folliculitis. If it's non-follicular, you want to think of other differentials. So what's the difference between a pustule and a cyst? So a cyst is similar to a pustule, however, it's a bit bigger, so it's more than 2 centimeters, and the fluid inside it is a bit different. Usually it contains serous fluid, okay, or serosanguinous fluid. So it is an elevated, circumscribed, larger volume lesion, so usually more than 2 centimeters. The elevation is related to dermis, and it's usually even deeper, by the way, than a pustule. So the elevation is related to dermis epidermis involvement, but it can be even down to the subcutis. How about vesicle and bulla? So vesicle is also very similar to a pustule. It has a similar size. However, the fluid is different. Okay, so a pustule has purulent discharge, whereas a vesicle usually has clear fluid. So serous, sanguineous fluid. You can have a little bit of bloody discharge as well in a vesicle. A vesicle and bulla are exactly the same. The difference is size. So here, even depth is not different. So I like to lump vesicle, bulla, pustule together and cyst. Those four because they're all fluid filled. And the difference between pustule and vesicle is the content. The vesicle and bulla is the size, and the cyst is size and depth. And this is how I like to put them together. So a bulla is very similar to a vesicle. However, it's larger, 1 centimeter, elevated, circumscribed, and primarily clear fluid. Some people describe lesions as blisters. Do you think blister is a primary skin lesion or no? It's not. Okay, so what is a blister? A blister is an umbrella term. When we say blister, it has both vesicle and bulla under it. But when someone calls me, let's say I'm on consult service and they tell me, well, I have a patient with, tense blisters on their chest. But I don't know, is it a small blister? Is it a big blister? Because it's going to change my differential. It could be small tense vesicles and they're grouped and it's herpes, but it can also be large tense bulla and they're scattered all over the body. It's going to be bullous pemphigoid. And that's why accurate description is important because blister doesn't tell me the size. It just tells me it's a water-filled lesion or, a clear fluid-filled lesion, but I don't know the size. But if I don't know the size, I don't know the configuration, how am I going to build my differential diagnosis? So you see why knowing these terminologies is important. So from now on, I don't want to see blisters and notes. I want you to either say vesicles. If you tell me grouped vesicles, I know it's going to be herpes. If you tell me if it's bulla in a dermatological distribution, I'm going to know it's zoster. If it's flaccid bulla, I'm going to know it's pemphigus. If it's tense bulla, I'm going to know it's bullous pemphigoid. That really does make a difference, okay, in building your differential diagnosis. And then we're going to move on to petechiae purpura ecchymosis. Again, they're all similar. They all are erythema so they're non-blanchable erythema because of RBC extravasation into the skin. But the difference between them is size. So petechiae is very small. It's less than 4 millimeter, where you have non-blanchable erythema secondary to extravasation of RBC into the skin. Purpura is 5 to 9 millimeter, and more than 1 centimeter is ecchymosis. And obviously, your differential is going to be very different based on each and every one of them. And then lastly is our special primary skin lesions, which are your wheals and boros. So wheals is basically a transient elevation of the skin due to dermal edema. Often in wheals, they tend to be erythematous, and then they have a pale center and an erythematous rim. Okay, so this is quite classic for wheal. And when we talk about a wheal, we automatically think about urticaria or urticarial lesions. How about a boro? If we describe boro, obviously we're all thinking about one thing, which is scabies. So it's quite specific. This is a primary skin lesion that's quite specific to scabies. And basically it's a linear tunnel, and this is induced by the scabies mite digging into the skin. Okay, so now we're done with primary skin lesions. Does anybody have any questions about primary skin lesions? We continue? Okay, so moving on to secondary skin lesions. So again, as I mentioned, secondary skin lesions are those skin lesions that develop either because of evolution of the disease or you have exogenous factors that are affecting your primary skin lesion or your normal skin, okay? So we're going to start off first with erosion, excoriation, ulcer, and fissure. I like to lump them together. Why? Because in all of them, you either have loss of your partial loss or full thickness loss of skin, or you're going to have discontinuity of skin. What does that mean? So over here, when you look at this erosion over here, you have a partial focal loss of the epidermis. So you're just losing part of the epidermis. It's like that your skin epidermis is peeling, okay? However, and then excoriation is very similar, but they're just linear. They're smaller and linear erosions, and usually they're induced by scratching. However, when you look at an ulcer is deeper. So you have full thickness loss of the epidermis and dermis as well, okay? But what's the difference between them? Because of this depth, this often heals without scarring. You can have post-inflammatory hyperpigmentation, but the ulcers usually heal with scarring because they're quite deeper. So how about fissure? So fissure is actually not a loss of epidermis, rather than it's an actual vertical discontinuation in the dermis. So the dermis is usually stuck, but you have a discontinuation that caused basically this fissure, okay? And usually we describe it as a crack in the skin. This is a common way. And I really like this diagram because it shows you exactly what we just talked about. So if you look at the erosion, you just have a partial focal loss of your epidermis, and excoriation is very similar. However, it's just smaller. So they're more small and linear. The ulcer is deeper, so you have full thickness loss of your epidermis that goes down to your dermis, and then your fissure is just a discontinuity in your epidermis and dermis, in the connection of your epidermis and dermis. So how about crust? So crust basically is just a collection of cellular debris because something was wet before that. Okay, so it's cellular debris either from serum or blood or pus or whatever it is. Okay, so usually it's a clue that your previous lesion, so your antecedent lesion, primary lesion, was something wet. So either a pustule, a vesicle, or a bulla. Okay. Scale is usually hyperkeratosis, and you have accumulation of this hyperkeratosis, so accumulation of your skin in your stratum corneum, either because of increased proliferation, like we see with psoriasis, or you also have decreased desquamation. In order for this to happen, it usually takes at least 2 weeks. So if a patient comes to you and tells you, this just happened yesterday, I woke up yesterday and I found this on my elbow, it's not true. Usually takes a couple of weeks for the skin to actually accumulate and form a thick scale on the primary lesion. How about lichenification? Lichenification is basically your skin markings. As you can see over here, you have an enhanced or increased in skin markings. And usually this is a protective mechanism of the skin because you're chronically scratching, so the skin actually starts to become thicker. And then the linings, the skin markings start to become more prominent. And usually this happens from chronic scratching, and it takes weeks to months to develop. So again, if the patient told you this has been going on for 7 days, 10 days, usually it's not true. The patient has been scratching this lesion for a really long time. So at least weeks to months until it became lichenified. How about atrophy? Atrophy basically just means focal loss. Either it's the focal loss of the epidermis, dermis, or subcutis. So atrophy, usually you want to palpate it. So you want to put your hand, close your eyes, and you're going to feel this indentation in the skin. So sometimes it's so thin that they call it a cigarette paper-like appearance, like what we see with cutaneous T-cell lymphoma, and that's when you have focal loss of your epidermis. However, whenever it's the dermis or it's the subcutis, it's definitely going to become more prominent. So this is what you see with your steroid-induced injections. So when you see the loss of fat or atrophy of the fat because of the steroid injections. And lastly, how about infarct? So infarct, from its name, obviously, it's the ischemia. This is considered a special secondary skin lesion whenever you have ischemia of the tissue. So obviously the color is going to change either from white to gray to black or even purple. Okay, so now that we described our primary and secondary skin lesions, what do we need to properly describe these skin lesions? Obviously, I'm not just going to tell you, I'm not going to call you when, when I'm on call, and I'm going to call you and tell you, well, I have a macule on the patient's back. Okay, by then, what are we going to do with this macule, right? So in order to be able to form a differential diagnosis, I have to know how many macules do they have? Is it single? Is it a few? Are they multiple? Are they numerous, packing all of the patient's body? The size is important, صح? So when you say macule, I obviously know it's small. When you say patch, I know it's big. But طبعا patch, if you tell me it's a 5 centimeter patch, it's different than when you tell me it's a 30 centimeter patch, right? So that's why size is also important. And then the definition of the lesion. Is it well-defined versus ill-defined? So what does well-defined mean? That if you get a pencil or a pen and you can actually draw it, this is what a well-defined border is. And ill-defined is that you won't be able to accurately draw the border around the lesion itself. How about regularity? So is the border itself regular or is it irregular? This also gives us clues. مثلا, let's say I told you, no, I have a single 0.5 centimeter well-defined brown macule with regular borders. But I tell you the same description, but it's a bit bigger. For example, it's like 10 centimeter with irregular borders. This is definitely going to change your differential diagnosis. For the first one, I can think, for example, of a cafe au lait macule. For the second one, I'm going to think pigmentary mosaicism. So you see how it's important, but they have the same color. They're both single. The only difference, and they're both macules, but the only difference is a little change in the size and the regularity of the border. Okay, so that's why you really have to be accurate when you're describing your skin lesions. Other than that is color. A lot of times, صراحة, we say erythematous, but honestly, when you describe erythema, you actually can help the person build a good differential diagnosis. But when you tell me it's salmon pink, I'm going to think of psoriasis. When you tell me it's orangey, I'm going to think of PRP. But that's why the erythema, when you describe it in a better way, it actually helps the person in front of you build a differential diagnosis. When you say it's dusky red, I'm kind of scared, because it's quite intense red. Usually we see it with drug reactions. When you tell me it's gray, I know that the skin is dying. So I'm actually very scared because it might be SJST. And but that's why color is very, very important. The smooth, sorry, surface also helps. So when something is smooth surfaced, when something is umbilicated, we have a whole differential for umbilicated papules. So molluscum, different infections like coccidioidomycosis and things like that. So that's why it's important. If it's verrucous, we're thinking of warts, things like that. Palpation is very important because palpation is going to let you know if it's obviously a macule patch versus a papule plaque, etc. If it's soft versus if it's firm or hard. For example, if you have a hard, papular nodule, you're thinking of, calcium deposition, for example. But if it's a little bit more firm and rubbery, you want to think of rheumatoid nodules. So really, palpation is important. Sometimes for vascular lesions, so is it blanchable or not blanchable? You're not going to know unless you palpate it, right? So it's going to change your differential. If it's a non-blanchable erythema, you're thinking more vasculitis, vasculopathy. Is it hot? Is it tender, etc. Okay? And configuration. What does configuration mean? It means the arrangement of the skin lesions respective to each other. فمثلا, if I have a single vesicle, this is discrete. But if I have grouped vesicles, I'm thinking of herpes. If I have dermatomal vesicles, I'm thinking of zoster. So not HSV, I'm thinking more of VZV. But that's why the configuration is important, okay? And the distribution and location obviously is important because, again, it gives us other clues. If I tell you it's in the sun-exposed areas, so face, dorsal hands, dorsal feet, it's sparing the submental area, I'm thinking of photodermatoses. If I'm telling you lesions are in hidden areas, in the bathing suit areas, or in the bum area, I'm thinking CTCL. If they're in the intertriginous zones, I'm thinking like a huge differential. For example, intertrigo, is it psoriasis, eczema, etc. It helps me build my differential. So I actually have to use all of these components in order to be able to properly describe a skin lesion and then apply all of this to my primary skin lesion. And then this will help me build my differential diagnosis. So I do have an example. I don't know if anybody would be comfortable enough to describe. I'm more than happy to have you unmute yourself and describe. So if you don't want to, I'm completely fine. I'll give you a minute to see if anybody wants to describe, or else I'll just go. ما تستحوا you guys. It's a very easy learning experience. No one's judging you, wallah. Anybody wants to describe, will I go ahead?
Okay, I think Dr. Zeinah في some people are willing to ريامي الزهرة أو BM. لو
Okay,
it's okay, you can go ahead and unmute yourself to describe the
definitely go ahead.
lesion.
Yeah.
Okay, I think we can't hear you الزهرة. Okay, في الشات في ناس كاتبين multiple lesions with the well-defined border plaque.
Okay.
Scaly. Multiple well-defined erythematous salmon pink plaques with scales.
Perfect.
Perfect.
Very good. Perfect. So I liked the person who you just read and said multiple well-defined erythematous, which is salmon pink plaques with scales. فخلاص, this is يعني, I know you guys are giving me the buzzwords to say psoriasis, literally. I love the way that you mentioned it. So the number is there, the border is there, well-defined, ill-defined, regular, irregular, doesn't really matter, honestly, over here. I love that you said salmon pink because the color is not just only erythematous, it made me think more towards psoriasis. Well, obviously, you guys can notice a little bit of the elevation in the skin, and that's why you mentioned plaqued. And I love that you didn't say lesions because lesions is not a primary skin lesion. You have to mention what the primary skin lesion is, which is plaque. And then you mentioned the secondary changes, okay, which is the silvery scales. Excellent. So someone also mentioned silvery scales. خلاص, you guys gave me the buzzwords words for psoriasis. Excellent. So this is psoriasis. بالنسبة للconfiguration, usually they're scattered. So I would like to say مثلا they're scattered all over the body. Sometimes we have intertriginous psoriasis, صح? That's why it's important to mention the configuration and the distribution. Over here, it's distributed on the trunk. That's excellent. Good job, guys. Very proud of you. Tamam. So now that we're done describing skin lesions on the skin, don't forget, as part of your examination, always look at the nails, always look at the hair, and always look at your mucous membranes. But these obviously have a whole different, lecture for nails specifically, hair shaft abnormalities, scalp abnormalities. But just in general, I'm gonna touch upon it. You want to observe the shape of the nail, the color of the nail. You want to look at the thickness of the nail. If you have hyperkeratosis, if you have subungual hyperkeratosis. You want to comment on not only the nail plate. So sometimes you have changes in the nail plate, such as pitting in the nail plate, onycholysis, but you also want to look at things that happen under the nail plate. So your onycholysis is basically separation of your nail plate from your nail bed. So these are nail bed changes actually. And you also want to look at the tissue surrounding the nail itself. So the capillaries, if you have any erythema in the surrounding area. So all of that is also important in nail examination. How about hair? You want to look at the hair, you want to look at the scalp, and you also want to look at the hair shaft itself. Okay. So you want to look at hair shaft abnormalities. Sometimes you can have broken hairs. Sometimes, you can actually examine them under the microscope to look for hair shaft abnormalities. You can perform a hair pull test, and obviously you can use your dermatoscope. So when you look at it when you use it to look at the scalp or the hair shaft, this is called trichoscopy, but it's exactly the same as dermoscopy. Lastly is your mucous membrane. So you want to look at your oral, ocular as well, especially when you have blistering disorders, and obviously your genital mucosa as well. So what we're going to do basically after we describe this lesion, why is it useful, as I mentioned before? So we want to use it to aid us in building a differential diagnosis, and that's why we use morphology. So it's basically a diagnostic integration. So once you describe, for example, the lesions that we just talked about, so the psoriasis plaques. We also mentioned the distribution. If it has a specific diagnostic pattern, it can help you recognize what this diagnostic pattern is, and then you're going to integrate it with the clinical context, obviously. They told you that they do have a family history of psoriasis. They said it happened, for example, a few months ago. They also have nail changes, pitting. They also are complaining of back pain or knee pain. They're not on any medications, but for example, you have a child who had an upper respiratory tract infection. All of these things you're going to build together with your morphology, and you're going to be able to reach to a differential diagnosis. Okay. Sometimes comparing multiple lesions, so your early lesion versus your late, is important, because a lot of times when you first see a patient, the lesion later on will evolve. So it's not going to present initially as your classic lesion that you usually tend to see, but the disease evolution later on can show you exactly the classic primary skin lesion. So sometimes, Haram, I see patients where they come to me and they tell me, well, I've been to so many dermatologists. It started 2 weeks ago and they didn't know, and then you got it immediately. But honestly, I tell them, you should شوي take it with a grain of salt what they're saying, because haram. So sometimes they present very early to the previous dermatologist and they just weren't able to diagnose it because it was so early. And then you got lucky when you saw them and they had the classic finding, مثلا PRP. They usually start early on. They're not your classic PRP. بعدين boom, when you see them, you have all of the findings of PRP, salmon pink, orangey plaques with the islands of sparing, perifollicular erythema, the PPK, and then you tell them, oh, super simple, it's PRP. But haram, they've been struggling for a whole year, but because they didn't have this classic presentation. So evolution of the disease as well later on can change, and morphology can change based on the evolution of the disease and activity of the disease. So all of these are going to guide you to do your differential diagnosis. Sometimes you may need to even biopsy, obviously, but you always want to biopsy your primary skin lesion, the one that has the least secondary changes, so you can be able to capture the disease and manage it appropriately. So helpful tips: compare lesions across sites, and this is what we were just talking about. Take time to palpate the lesions. I always tell residents, palpate. Don't just look at the lesion. Practice precise terminology. So this is very important. Practice it when you describe it to your physicians or to your colleagues, and also when you write it in your examination. I see a lot of residents, they just skip the whole physical examination in the chart. A physical examination is very, very important. You should mention it because when we follow up patients, we want to know how it used to be, how it became. You want to comment also on the body surface area as well because it will help following up a patient and assessing their management. So this is also an important part. And always try to describe before diagnosing and build a differential diagnosis. But I always say practice that. The more you practice, the easier it becomes later on. You start becoming fluent in morphology. Document with standardized photos whenever you can, obviously after the patient's consent, and review cases regularly to build visual memory. This is very, very important because with time, like I said, morphology becomes your native language. It becomes very easy for you to describe lesions accurately. The other thing is the more you see, the more you're going to be able to actually reach to that spot diagnosis. خلاص, the more you see different lesions on different skin types, different lesions on different colors of patients. They present differently, but the more you see it, the more you're going to be very confident describing it and knowing it immediately without needing to go through the whole list of differential. But still, in the beginning, build that list, build that list, build that list until you become خلاص, very confident with your initial diagnosis and your spot diagnosis. So key takeaways, skin exam is systematic and detailed. It's very important. Morphology is actually the foundation of dermatological diagnosis. So your start of your diagnosis is the beginning of your diagnosis starts with accurate morphological description, building your differential diagnosis, bedside tests, investigations. Biopsy comes last actually because it supports your diagnosis and then you're going to reach to your diagnosis. Sometimes just from proper morphology, you can actually accurately reach a diagnosis. So morphology plus distribution gives you diagnostic pattern recognition. Always describe accurately before naming the condition and use morphological descriptive guides, using those morphological descriptive guides aids your differential diagnosis, biopsy site selection, and management. That's it. Any questions, you guys? Yeah, it's very basic. It's 101. Yani, I'm sure you guys have heard this a lot. But honestly, the major take-home message is I really want you to practice. Practice your morphology. Practice building your differential diagnosis.
يعطيك العافية دكتورة زينة for the wonderful lecture. Thank you so much for your time and joining us today and despite your busy schedule. والله.
You're most welcome, wallah. Anybody has a question, you guys? And I didn't go through the chat.
Oh, yeah, we will now open the floor for a 10-minute like Q&A session. I can read you like the questions out